Welcome to today's Explainer. We're diving straight into a fascinating anatomical mystery. Seriously, this is a story about how an incredibly high-risk surgery was totally transformed into a routine success. And the crazy part? This wasn't achieved with some million-dollar robotic laser or brand new technology. Now, it all came down to a ridiculously clever, almost cartographic understanding of the human body. We're talking about surgical ingenuity, literally finding hidden pathways, and a simple shift in perspective that ended up changing the lives of countless patients. So let's set the stage with a really high-stakes question. Imagine you're a doctor. How do you safely perform a vaginal hysterectomy when the patient's abdomen is basically a maze of unpredictable scar tissue? We're specifically talking about patients who have a history of abdominal surgeries, things like C-sections or myomectomies. For the longest time, a prior C-section was a huge, flashing red warning sign for this type of procedure. It was often considered a flat-out reason not to do it. And it all comes down to that internal scarring. You see, this scar tissue, which is formally called vesico-uterine adhesions, is the ultimate roadblock. When someone heals from a C-section, this dense, super tough scar tissue frequently forms right between the urinary bladder and the uterocervical surface. So if a surgeon has to go in later to remove the uterus, these adhesions pose a terrifying risk. The organs are essentially superglued together. Trying to separate them creates a massive risk of accidentally traumatizing the bladder. Because that fear of bladder trauma was so severe, surgeons traditionally had to resort to open abdominal surgery, complex, highly invasive laparotomies, or they'd have to stick cameras into the abdomen first just to see if it was even safe to keep going. We're talking longer recovery times, way more anxiety for the patient, and obviously higher medical costs. But today, the new reality is completely different. It's a fast, safe procedure done in just 20 to 90 minutes, and it is all thanks to a hidden anatomical passageway. Section 1. Finding the secret window. While two surgeons, Dr. Das and Dr. Sheth, just didn't buy that invasive open surgery was the only option here. They had a hunch there was a better route. And they realized something absolutely crucial. The scarring from a C-section isn't a solid brick wall. It's not everywhere. It's actually heavily concentrated right in the middle. The central 3/5 of the bladder area is typically where those dense, tough adhesions lock everything down. So if a surgeon takes the direct, straight-ahead route, which, feels like the most logical path, they're actually marching straight into the thickest, most dangerous part of the scar tissue. But here is the real game changer. By just moving slightly to the outer edges, specifically that lateral 1/5 on either side of the danger zone, surgeons found a totally untouched, safe plane. Even when the center is completely fused together, this lateral area remains pristine, completely free of scar tissue. It's literally like finding a perfectly unlocked side door when the main gate is heavily barricaded. In medical terms, this little side door is called the uterocervical broad ligament space. Think about its borders like a hidden room. The ceiling or anterior border is the undersurface of the bladder, and the back wall is the uterocervical surface. Inside this space, it's mostly loose areolar tissue, which is super easy for a surgeon to navigate. But the absolute most crucial detail? The ureter, which is a highly sensitive structure you definitely do not want to mess with, is safely far away from this pocket. This window completely avoids the ureter, while giving surgeons a clear path to detach the bladder safely. Section 2. Proving the space exists. Now, before anyone starts attempting to bypass dense scar tissue on actual human patients, the medical community needed hard, undeniable proof that this invisible corridor wasn't just a theory. So they used some really clever diagnostics. First, they used methylene blue dye. They injected it abdominally and literally watched where it flowed. It stained that exact lateral space dark blue, physically proving there was a continuous, open path. Then they backed that up with repeated MRI scans. And sure enough, the imaging clearly showed a distinct, vacant space exactly where they predicted. The secret window was officially mapped out. Section 3. The breakthrough technique. Okay, so you know the space is there, but how do you actually navigate it without causing harm? Here's the brilliant 4-step technique they developed. First, you make a standard incision, but then, and this is the trick, instead of pushing forward into that central mass of scar tissue, step 2 is cutting upwards specifically on the outer lateral margin. Step 3, the surgeon actually introduces a finger into that newly opened side window to enlarge the space. And finally, step 4, once safely inside that lateral pocket behind the bladder, they just sweep their finger inward, medially, to break those tough midline adhesions safely from behind. When you visualize this lateral approach, it makes total sense why it's so safe. coming in from the side puts the surgeon's finger perfectly between the bladder in the front and the uterocervical area in the back. They get clear vision, they get tactile feedback, and they can basically snap those central adhesions from the inside out instead of fighting them head on. And the results of doing it this way? Absolutely revolutionary. By exploiting this anatomical loophole, surgeons completely bypass the need for invasive diagnostic cameras or opening up the abdomen. You didn't need to look from the top down anymore to see if the adhesions were too bad. This lateral window pretty much guaranteed a safe path, no matter how thick that central scarring was. Section 4. Flawless real-world results. To really grasp how big of a deal this is, let's look at the clinical data. Dr. Das and Dr. Sheth tested this on 106 consecutive women. And keep in mind, every single one of these 106 patients had a history of C-sections or myomectomies. That means they all came into the operating room with presumed high-risk adhesions. Traditionally, these are the exact patients who would have been routed straight to open abdominal surgery. But check out this outcome. 0. Out of 106 high-risk patients, there were exactly 0 cases of bladder trauma, 0 damaged ureters, and 0 need for any laparoscopic assistance during the procedure. The success rate for separating the bladder using this hidden space was literally flawless. So instead of an anxiety-inducing hours-long ordeal with a huge abdominal incision, these surgeries were incredibly efficient. Standard operating time was just 20 to 90 minutes. Even when surgeons ran into the most severe stubborn adhesions, using this side window only added maybe 5 to 20 minutes to the clock. Plus, because it's so minimally invasive, they could easily combine it with other necessary procedures all at once. They proved that a major surgical roadblock could be elegantly and quickly sidestepped. This whole explainer really highlights the brilliant, almost puzzle-like architecture of the human body. By just shifting their perspective a few centimeters to the left or right, these surgeons turned a highly dangerous obstacle into a completely routine procedure. And it really makes you wonder, as we keep mapping out the intricate geography of our anatomy, how many other secret passageways and hidden windows are out there right now, just waiting to be discovered to revolutionize the next impossible surgery. Thanks for hanging out with me for this explainer. Keep questioning, keep learning, and I will see you next time.